record to the, yes. Dr. Guthrie is here today and she's going to be presenting, and welcome Jamila, Aisha, Asia, Zainab, and the rest of the ladies joining us this afternoon. We are going to be talking today the last stage of pregnancy and what to expect when you go to the hospital. And what a great way to start this, because this coming week is going to be maternity week. Is it right, Faiza? Maternity health week?
It's a Black maternal
health week. Yes, it's in my calendar. So what a great way just to, welcome.
I can't share my screen.
Oh no, I need to give it to you. Okay. Make you co-host, sorry.
And I wanted to say, when I was preparing this talk and putting different things in it, I was thinking this is such a big topic, as you all know very well. Yes. And so today I was gonna kind of do an introduction of different reasons to go to the hospital and kind of a normal, I guess, normal vaginal delivery. And then was thinking maybe in the future we can talk about more about C-sections and more about inductions of labor. Yes.
The risk
for those things.
We can talk about the last, maybe next month we can talk about the risk, the amount of cases when she comes to the hospital, like induction, C-section, baby heartbeat and all those things. Milgo, come on, welcome, Abayo. Yeah.
I'm talking about a couple of them today, but I think there's more to talk about. And I also want to say that I am coming from a very narrow perspective of birth, that I am a doctor trained in this, in Swedish specifically, and a family doctor. And I don't have the same training as a midwife. I don't have the same training as doulas. And I'm also not a mother myself. So I don't have personal experience from that perspective. So I want to say I have a very narrow, I don't want to even say expertise. And I want to acknowledge that all of you have a ton of expertise in this. And so I want this, I want to kind of introduce more from how, when you maybe have a medical doctor and sometimes midwife, although midwives often have, a little bit of a different training and different breadth as well. That's amazing. So I just wanted to introduce it from that perspective and explain some of the things that patients going into the hospital might hear, might experience, might have questions about, to kind of demystify, make it a little bit more clear of why we do certain things and what certain things might happen.
That's a good idea.
So I will open some slides. Please interrupt me if you have questions or want clarifications, or if you feel like you have a story or something to say that I'm not including, that you think is important to say about whatever I'm talking about. That being said, I also want to honor your time and not, I will try not to take too much of your time. And I'm trying to load my PowerPoint, so we'll see.
Computers, they don't agree with you when you need them the most.
Right?
Yep.
Let me see if I can fiddle with my internet a little bit. Sorry about this.
Oh, no, take your time.
In the meantime, who's making what for dinner tonight?
Oh, nothing but simple.
Sorry,
white
but
Good, I like that, Najma, I like that.
So, Milgo is here, by the way, and I did not know Milgo used to be midwife.
MashaAllah. Assalamu alaikum.
Dula.
Dula, yes.
عليكم
this one.
السلام.
Yes.
Set
How are
Abai.
you, Abai? Good, alhamdulillah.
Alhamdulillah في عنا set هاي.
I'm good. Are you guys back? Last I knew you guys were in Saudi
Yes,
Arabia.
they are back. They are
ها
back.
ها. وصل
MashaAllah.
نقضي أباي.
That is
I'm
so
here.
awesome.
Something wrong with your Minecraft.
Abaya, yeah. Last I knew فيلم القرآن أيضا مشهور.
Yeah.
إذا كنت مشهور جورا أنا أوكي.
ها. ها هذا صار نقضي أباي. set في عنتي.
Perfect Abaya. Alhamdulillah.
Long
في عنا.
time. ملا
I
مركي
know.
apartment تيجي سل دقنينا اسكايدم بساملنا long time.
Subhanallah, it's been even Hoyla the Brian Markin. Subhanallah, I used to see her at Dukanka Hoy Imagerty. Remember the one?
wait ماذا believe me.
Willie, yeah, mashallah.
Yeah, every week مرة. كلها إيجا ماما إيجا كلها هاي مالك أفريقيا السعودية you know ماشي كيليس
Mashallah, yeah, oh mashallah.
yeah she always go there so Dula is group بدن مهشين هذا أنا بدك يوهر يعني ليلى يوسف يعني لبلابي Dula
MashaAllah.
beginning ها
Wow. La fi right here, ha.
Judy مش الله شقين جري you know
Judy, I'm not sure who.
and Rainier Beach midwife Judy.
Lazarus.
يا لسه ما هم سلاسلي ahead.
Leslie.
جوجا لسما حقوين.
Yes.
Yeah, Leslie. يا Judy. يا group كاسان لشقين جريم.
Awesome. Maya, hatta anaga, we have our own doula organization. So yeah, feel free to look it up. I'll put the thing in the chat so that the doctor can start.
But what we love with done in a I have to come mark as a man like
So I might just go with this and not have a full screen.
Yeah, go ahead.
Just for time. Sorry.
I'm sorry, Amelia.
It's
no, sorry. So I just wanted to start out by talking about sorry. Oh,
go ahead.
Unshare, stop share. Okay. Sorry, guys.
Okay.
My computer's like freezing, I guess.
It's like, what are you doing, Dr. Guthrie?
I know. Here we go. Okay. Let's try that again. Okay, let's try to see.
I like those things that show up, the centimeter things.
Yeah.
The one thing I like about two hospitals that I go to all the time, Highland, and also another hospital, what is it called? The hospital in Federal Way, St.
Do you like that hospital?
No, not like they have
San
Franciscan. They have you know
San,
like
nobody likes that hospital.
San Francisco. Nobody like I guess nobody goes. Last time I know.
Yeah, they have the you know like they have these things like tray. It has like the how many centimeters moms open, which is cool.
Okay. It's a picture.
Focus on like what it is centimeter, like how much you're open, like it looks different.
Oh, that helps the mothers
to visualize it,
to understand.
Yes, and last night finally, I get to have a Somali mom to look at her vagina while she was pushing. And it helped.
That's so great.
The mirror?
Yes, the mirror.
Oh, she's saying I'm almost there, so she kept pushing it.
No, first she said no, because most Somali women, they say no. This one, at the end, she was like, yes, bring it here. Bring it here. And we were like, brought it in. And she's like, yes, let me see. I was like, oh, this is what I'm talking about. Let's do this. Let's do this. And trust me, it helps. Yes, bring that vaginal to the mirror. Helps out. Push at the door. Sorry.
Wow.
You know, I get all excited about vaginal stuff.
I get nervous.
So I'm having so much trouble getting my slides up, you guys. I don't know what's going on. My internet is really
slow?
not like this. Slow. Yeah. I'm gonna try one more thing.
We could see it small, but not when you know, when you click it to present it. But we can see them small, like on the side.
Can you hear me okay?
Yes.
Okay.
Yes,
Okay, so maybe this is working. We'll see. So I wanted to start off by kind of defining what labor is when we talk, when we think about it in the medical field. And so can you guys see this, like this slide on here?
Yes.
Okay. And so in medicine, we define labor as the uterine contractions that are causing your cervix to change. And so sometimes you might feel painful cramping or contractions. That's not changing your cervix. And that is uncomfortable, but not real labor. And the cervix changes in a lot of different ways. Most people think about the cervix getting wider from 0 to 10 centimeters, which you can see on the bottom of that slide. But it also gets thinner and softer and lower down in the pelvis. So those are all numbers that when a doctor or midwife is or a nurse is examining someone, they are thinking about that in terms of cervical change. Softer, how open, how thin, and how far down. We split labor into 2 different parts. Early labor is less than 6 centimeters dilated, and this can be a long, long, long time. This can be even a few days of getting to 6 centimeters. And active labor takes a lot shorter time to get from 6 to 10 centimeters, about 4 to 8 hours on the long side, but sometimes 30 minutes, depending on how many babies you may have had in the past. So if someone is feeling like they're having contractions, what's the next step? So usually we recommend starting to time how far apart and how long contractions are lasting. So start timing contractions, be in a soothing environment, and call your doula and your midwife and your doctor to talk about the next step. Oftentimes we talk about this rule of the 5-1-1, 5 minutes between contractions lasting for 1 minute, and that pattern lasting for at least 1 hour. That's something we tell a lot of people, but if you've had a history of a really fast labor, then you probably don't want to wait until your contractions are in that pattern. You might want to talk to someone a little bit earlier.
Definitely.
Yeah. And so, as I was saying, I work at Swedish hospital. So that's my perspective. And I took on their website, they have a little video tour of the labor and delivery floor that I screenshotted. So the first step is going to triage, which is like the emergency room for pregnant people who are above 20 weeks. So if you have any sort of concerns or you think you're in labor, that's where you go. And most hospitals that have labor and delivery floors have this kind of place. This is what it looks like at Swedish. You go into triage, there's a nurse there. They talk to you, they get you on the monitor and monitor your baby. And then they call your midwife or your doctor and have them come and examine you. Oftentimes, they'll do a cervical exam, like I was saying before, to see if your cervix is making change. And sometimes if it's making a lot of change, or if you're close to active labor, they'll admit you to the delivery room. But sometimes you're not quite making that much change. And the hospital is not the most restful or the most soothing environment. So we don't really recommend having that long, slow, latent labor in the hospital. It's a lot more comfortable to be at home in an environment that you can control. And so sometimes we end up sending people home when they're in early labor. Sometimes we can send people home with some medicines. We can give shots of medicines for nausea and for pain if the patient wants that, to maybe have a nice restful nap while they're in that early labor. As I was saying, that triage is kind of like an urgent care or emergency room for people who are pregnant. So there's other reasons why you might go to the triage besides thinking that you're in labor. And so these are some common complaints that we see when we're working with patients in the hospital. If you think that your water might have broken, which sometimes is a huge gush of fluid, like the movies, and sometimes it's really subtle, kind of continuous leaking. And so sometimes when it's not so obvious, we do an exam where we look inside at the cervix. We can see if there's any fluid pooling in the vagina, and we can test that fluid to see if it's the water that's around your baby. And if your water broke, we often recommend that you stay in the hospital so that we can monitor and manage your labor and delivery. Another common reason is feeling like your baby's not moving as much as normal. So we would usually in that case put a monitor on your baby and then sometimes do an ultrasound to take a look at baby and look at how baby's moving and breathing and everything like that to make sure everything's okay. Sometimes people have high blood pressure that they're seeing their doctor or midwife for, and they might check at home and notice that their blood pressure is high, or they have a headache or vision changes or swollen hands or feet or face that are worrisome. And that's another reason people go to triage, and we do some blood work and monitor your baby. Common theme of monitoring the baby in this. And sometimes if you're noticing vaginal bleeding, that's also a good time to go to triage. Again, we would do a vaginal exam, do some blood work, and do an ultrasound to make sure there's nothing dangerous going on. Any questions people have about that?
Sometimes the cocktail medicine that you guys give, I noticed that some of the moms, they don't like it. Can they just go home without the cocktail medicine?
Okay. Yeah, that's definitely an option to decline that medicine. And it does feel, it's a strong opiate pain medicine that's a shot. So it can sometimes feel very strange. And so it's definitely reasonable to choose not to have that and to go home and use a lot of other methods to manage the pain of labor.
Especially mom who's a user, you guys wouldn't allow that, right?
I don't have an answer to that. I'm not sure if we say that that's not at all allowed if someone is using, but.
I mean, if they tell you and say, I'm in a recovery, I mean, if they outlaw,
Yeah, a lot of times people don't want to if they're in recovery, but.
Of course, yes.
But sometimes if people are in recovery and they're in a lot of pain, it might be helpful. So it depends on the person.
User maxaa ka wadaa like wax isticmaalaa drug or something?
Drugada isticmaala, yes.
Okay. Yeah.
Yeah. And one medicine is an opiate and the other medicine is a strong anti-nausea medicine. So sometimes just that can be helpful too.
To relax them most of the time. Anti-nausea.
Yeah.
I like the bath.
I wish that one was in my room right now. Sure.
I know. So this is a picture at Swedish, a delivery room, and the bathtub that's there too. So in this picture, you can see the delivery bed that has all these robotic parts that move up and down and all sorts of positions. And then
I have a question.
Yeah, go ahead.
If patient don't want to take any medication whatsoever, what kind you have like a soothing for them, like to help them to go through the birth?
Yeah, that's a great question. And I actually on the next page talk a little bit about that in terms of pain control. So oftentimes, the bath, taking a bath can be a really good way to manage pain. And then also all sorts of movements, being on a birthing ball, walking around, leaning against a partner or the bed, getting massages can be really nice. And then breathing exercise to calm down the body and be kind of really intentional about feeling the body and calming yourself. Dim lighting, good smells, good music, all of those techniques. And I have to say
that's
that
when doula becomes very handy.
the doulas
Oh
are the
yes,
experts in this.
definitely.
And I don't have as much expertise at all as doulas do about all of these really wonderful techniques that are not medication. Yeah.
Amelia, do you all offer nitrous at Swedish?
We don't, unfortunately. Yeah, I wish we did. Yeah.
What is that, Faisa?
I think that university, I might be making this up, but I think that Northwest Hospital might, or the
I know you did, yeah. The U has.
Hospital do.
Yeah. And that's nitrous is like a gas that you breathe in.
Oh, it helps a little bit. Oh, that would be nice. Yeah.
Yeah, it helps pain.
It's not gonna damage anything, but it's just when they have overwhelmed the pain, they just give it to them a little bit.
Yeah. So
Swedish, they don't have it.
No, Northwest Hospital one time used it for my client. I remember that one for sure.
And how was that? Did she like it?
Yeah, she really liked it.
Yeah,
I can tell. I used it.
And she had the baby too, because the baby was right there. She was running. She was just really.
And they want a medication, right?
She was holding like tight, but the baby was there. So the midwife gave her that gas thing, whatever it was called. I don't know. I call it gas.
Yeah.
That relaxed, and then she began to push, and then baby was smoothly. Yeah, it was nice.
They use it a lot in the UK.
Ooh.
But the nitrous gas,
I used it in Saudi Arabia when I was having my child. I was telling them I need epidural this time, but the baby was right there, so they give me that.
And it's nice that
mask. It helps.
Yes, it does.
Yeah, it makes you relax.
Yeah, and then you don't have to worry about the timing of the epidural.
No, I was, where is the epidural? And then when they give me, I was like, okay. Then I just deliver like 2-3 minutes later.
Oh, wonderful.
Yeah, it helps.
Same thing that mama did too. 2-3 minutes, baby was.
Yeah.
Obviously, like you said, it was right there. My baby, I guess it was right there. I'm calling them like, where is the epidural? When is gonna come? They say, oh, they're gonna come right now. Just use this one. That's it. I deliver. So yeah, it helps a little bit, the pain.
Yeah. So those are some great points too, because so unfortunately we don't have that at Swedish, and I'm glad that you brought it up because I didn't include it in this slide, but I'm glad we could talk about that as an option, because it's a good option if it's available.
Yeah.
I'm hoping that in the future Swedish will have it, but not at this point. The other options that we have at Swedish and that might be available are IV narcotics. The one that we often offer at Swedish is fentanyl, and that's a pretty short acting. It can last for like an hour, but in the context of labor, that's relatively short. And it can make both mom and baby sleepy. And we don't recommend it right before delivery because it can make baby sleepy during delivery. And we really want baby to be active during that transition to life outside of the womb. So we don't recommend it within that first hour or that hour prior. So if you're really close to delivering, it's probably not the best idea. But it can be helpful kind of in the other parts of labor. An epidural is also, it can be very effective for pain control. This is a picture of someone getting an epidural where it's a needle that goes into the back, and there's medicine that's delivered to the fluid around the spine. So it causes numbness of the spine and the nerves exiting the spine. And at Swedish, there's different rules at different hospitals, but a couple things that are a little bit kind of some drawbacks are that at Swedish, there's a concern that if you get nauseated or something, that you might throw up. And so we only recommend clear liquids, which can be like Jello or broth or something like that, but not real meals when you have the epidural. And then it's hard to move because your legs are numb and heavy. So oftentimes you have a catheter in your bladder to help you pee because you can't feel the need to pee and you can't get up to go pee, and it's hard to move around. So these other methods of pain control where you're walking around, or these other positions you might want to be in, are hard to get into, and oftentimes you need a lot of help to get into those positions. So those are some drawbacks, but it's very effective for pain. So everyone can kind of make their own decision. And at Swedish, a lot of people do get epidurals, but it's totally up to the patient, and they can decide at any time as long as they're able to sit on the edge of the bed and get that procedure done. So if your baby is right there almost crowning, it's a little bit too late because you can't sit down at the edge of the bed, but otherwise it's an option. So I wanted to talk just a little bit about some complications.
Can I say something quickly?
Yeah.
Sometimes mom, they don't like the catheter to be left their own. And I've seen it where the nurses just come in and they just drain the bladder and then come back and drain. Okay, good.
Yeah.
So that's also optional, right?
Yeah.
Great, that's good, thank you.
Yeah, definitely. So sometimes when there's a lot going on, there's a lot of tubes that you might be attached to. Sorry, this light is so strange. I'm gonna try to, it's very sunny in my house, so I'm gonna try to be less, okay, maybe a little better there. Okay. So not having a tube attached to your bladder is one less tube that you might be attached to. Oftentimes when you get admitted to the hospital, we recommend having an IV in place so that you can get fluids if you need to through the IV, or medicines if you need to. Sometimes just having an IV in place without it attached to anything is an option. So you can just ask it to be saline locked, and then it's just in your arm, but it's not attached to a tube and an IV. And that's a little more freedom to move around too. So some complications that might happen during any normal labor is that labor is slowing down or stopping. So I talked a little bit in the beginning about how that active stage of labor usually can last up to 4 to 8 hours. It depends on whether you've had babies before, how long that takes, and it depends on a lot of other things too. But there's some things that doctors and midwives can try to speed up labor if that's something that is either medically advised in the case where possibly baby is under a little bit of stress and we want to hurry things up, or just talking to your medical team and talking to the patient about what everyone wants to do. So some things that patients might hear about are breaking water, so not waiting for the water to break on its own, but breaking it can speed up labor because there's a lot of hormones in the amniotic fluid that can help speed up labor. Giving medicines like Pitocin, which is a synthetic form of oxytocin, the hormone that your body's making to help labor go forward. And then sometimes internal monitors can be placed. This is a picture of the internal monitors that we use. So this is a side view of a pregnant person and their baby. And so there's 2 monitors in this picture. One is a fetal scalp electrode, which is something that can better monitor baby's heart rate. And that's placed on the scalp. And so it's a tube that's placed in the vagina and then onto baby's scalp. And it's a little kind of metal, kind of a metal thing that's placed into the scalp. Sometimes it leaves a little bit of a scratch, which is safe for baby. It doesn't really cause pain. And then the other And then the other monitor that you can see there is a catheter that goes just inside the uterus and kind of floats next to baby and monitors the exact strength and frequency of uterine contractions. So the outside monitors on the outside of the belly monitor how frequently contractions are going, but not the exact strength of them. So it's hard to know exactly how strong they are unless you have this internal monitor. So that's something that that sometimes happens or sometimes is offered to patients or discussed if labor is slowing down or stopping. And then if labor is really stopping and not going forward, no matter, and it's been hours and hours and hours and different things have been tried, sometimes a C-section is offered to deliver the baby. And then another complication that can happen at any time for a lot of different reasons is baby showing signs of stress. So labor is stressful for babies, and they've been hanging out in the uterus, and then all of a sudden there's getting these contractions and they're getting kind of pushed out of their what they've known to be their home, and it can cause some stress. And we often see that on the heart rate monitor, and that can be a normal part of labor. Sometimes stress, there can be different reasons for that. Sometimes there's a cord that's wrapped around baby's body, and with contractions and positioning, that cord gets squished, and that we see those signs of those on the monitor. And so if we see that the baby's heart rate is going down, or the baby's heart rate is going down in certain patterns, then sometimes that's when a team of doctors and nurses and midwives might run into the room, and there might be a little bit of excitement. The different things that can be done to try to make baby less stressed and have the heart rate look a little bit more normalized is changing position. So oftentimes if the if your body is in a certain position, baby's body might be in a position that is causing their heart rate to go down. And so changing the position, in the bed from back to front, side to side, even on hands and knees can make the baby's heart rate normalize and look more healthy. Sometimes this can happen when patients are a little dehydrated, and so giving the moms IV fluids can help baby's heart rate. Sometimes it's because the contractions are too strong and too close together, and so giving medicine to stop contractions can help the baby get a little bit of a break. And again, putting monitors on the baby or the patient can help understand what's going on and get a better sense of baby's heart rate and how safe things are. If the baby's heart rate is going down and it's staying down, or it's in a pattern where there's lots of repeated dips, we get worried that the baby's not getting enough oxygen to its brain, and that can be dangerous for their development in the future, neurologic development in the future, and also about just their safety and their ability to kind of withstand labor. So if that's happening, then it can be a little dangerous, and there might be a recommendation of a C-section. There may be if this is happening and the patient is really close to delivery, this is possibly when you might hear something about a vacuum delivery. If someone needs to if the baby needs to get delivered fast because they're showing a lot of signs of stress and there's some concern that their heart rate is in a dangerous place, then there might be a recommendation to use a suction cup on the baby's head to help pull out baby while you're pushing baby out as well. So just give a little bit of assistance to help that pushing stage happen faster. There's also another type of assistance that's called Forceps, which kind of looks like little, I don't know, salad tongs maybe, where that's placed next to baby's head, and it helps kind of maneuver baby out of the birth canal as well. So those are some options if this dangerous situation is happening and you're close to delivery. Those might be discussed. A C-section might be discussed. So those are some complications when baby is showing stress. Sometimes baby could be showing stress and then you change position or you give some fluids and baby's heart rate gets back to normal and everything can kind of go back to being, having less interventions. Sometimes it keeps happening, and sometimes you can never know going into a delivery or into labor whether this is going to happen or not, or how the baby's going to react to labor. So yeah, anybody have any questions about all of that?
Sometimes babies, they can get hurt with the forceps, right?
Yeah, there's definitely complications to all of these things. So forceps are something that not every doctor does or knows how to do. Some doctors at Swedish hospital, and I'm sure other hospitals, are very good at them. There are certain positions a baby has to be in order for forceps to be an option. And so, you know, those positions that baby is in can make it easier and make sure that there aren't going to be complications. But certainly there could be complications, like there could be cuts to baby's face, there could be twisting of baby's body in certain ways that can cause you know, some injury. I've never done forceps and I'm not gonna do forceps, but I've seen forceps done, and the people who I've seen do forceps are good at them in a way that they don't have those complications. But it's something you can't really predict. And a lot of times the doctors who are doing these interventions are doing them because they think that the risk of baby not being born faster. So I guess the risks of being born with forceps, which could be fine or could have some of those injuries to baby, is safer than baby not getting born faster. So that's always the thing that the midwives and doctors are thinking about, is the risk of interventions. And all interventions, all the things that we do in medicine carry some risk. And whether those interventions risks are less than the risk of not doing anything. Does that make sense?
Yeah, I think timing is everything with these things, because you could have done C-section, but C-section is the person doesn't have an epidural on board, you know, but the baby is in trouble. Like oftentimes that's when I've seen people use the forceps or the vacuum.
Yeah.
It's just because and that baby's heart rate is dropping like drastically. And yeah, so the providers are keeping all this stuff in mind when they sort of decide to do it. Yeah.
Yeah. And sometimes if you have been pushing for a couple hours and the baby is close to delivery, but, you know, maybe looks like it's going to take another hour of pushing and baby needs to be born now or in the next few minutes, a C-section sometimes in that position is a little bit higher risk because the baby's down in the birth canal versus up in the uterus. So often that's what people are thinking when they offer something like forceps or a vacuum delivery. But yeah.
Doctor, just following up on that, you said not all doctors are sort of like trained with forceps and the vacuum suction. So if a doctor is not familiar with it, is there like backup for another doctor to be present while the woman's giving birth, just in case, or do they just kind of go ahead and do, you know, what they can with what they have?
That's a good question. So at Swedish, there's always so family doctors and midwives aren't trained to do like C-sections. all the time. Sometimes they are. It depends on the person. But OBGYNs are always trained to do C-sections, and most of them do, and vacuums. And so at Swedish, there's always OBGYNs who are on the floor, like a few feet away, that are trained in these things. So even if your provider, even if a patient's provider is not trained to do those kind of those higher level procedures, there's someone a few feet away who can. In other hospitals, they don't always have an OBGYN in the building all the time, but they're always on call, at least 15 minutes away. So it depends on where someone is. And I'm not sure about different birth centers. It depends on the facility of whether a doctor who's trained in kind of in the C-sections or in operative delivery is how close they are. Yeah. And I think maybe next time we can talk a little bit more about inductions and complications, and how some pregnancies are a little bit higher risk and might need more monitoring or more testing or things like that. And we can kind of get more into that because it's a whole topic. I wanted to talk a little bit about pushing. So pushing can, if you've had many babies before, can take 1 minute or less. But for a first-time mom, the average is 2 hours. And so it can take anywhere from 1 to 4 hours at the outside for a first-time mom to push out a baby. And I'm not sure if there's questions. Oh, so for babies' heart rates going up instead of down, both can happen. So the heart rate monitor, and I should have put a picture in here, I'm sorry I didn't. Baby's heart rate, the baseline, we want to be between 110 and 160 beats per minute, which is a little faster than an adult's heart rate. And we want to see it be mostly stable with a little bit of ups, showing kind of that we call accelerations. If a baby's heart rate is going up, where the baseline is above 160, we call that tachycardia. And that's a sign of the baby being under stress. And that can sometimes happen if there's an infection going on. But a lot of times we talk about deceleration, which is when the baby's heart rate goes down, and either is down for many minutes or down for a little bit, but then comes back up and then goes back when those decelerations are often when someone is going to come in and say, okay, we need to move you from side to side, and we need to maybe give you some medicine to stop your contractions, and all of those interventions. So during the pushing stage, so there's, and I wanted to say there's a lot of different ways to push. Oftentimes when you're in a hospital, the nurses, doctors, midwives might recommend a common technique where you hold your breath and you bear down for 10 seconds, and then you do 3 pushes per contraction. And a little bit of background is that when you're pushing during a contraction, your uterus is doing most of the work. So you're just pushing on top of what your uterus is already doing with those contractions. So you really want to time up the pushes with the contractions. Oftentimes when people have epidurals, they don't feel their contractions very well, or they might not feel an urge to push. But if someone, and that's when coached pushing comes in, which is typically this, what I was mentioning before, of holding breath and pushing in a certain pattern. When people don't have an epidural, oftentimes their bodies are really doing a lot of signaling to tell them when and how to push. And they might feel this really unbearable urge that they can't not push. And so in those situations, it's often better to kind of follow what your body's telling you to do. Unless there's certain situations where you might be told to stop pushing. And we can kind of talk about that a little bit later. There's also many positions to push in that can be really helpful. And this is another thing that doulas are absolute experts in. And these are some pictures of just different types of positions that people can be in. If someone has an epidural, sometimes it's a little harder to get into certain positions, like being on your hands and knees is a little hard to do when your legs are numb and you can't really support yourself on them. But I wanted to include a picture of this thing called a cube that is this really cool kind of blow up pillow that can support your body in a way. If you have an epidural, sometimes you can even be on hands and knees with certain types of supports and pillows and people's help. Sometimes the different positions can feel better to your body, and other times it can help the baby move around in a certain way that can be more helpful for the baby getting delivered. During the process of pushing, the doctor or midwife might come in and do similar to a cervical check to check how far down the baby's coming or what position the baby is in. And I'll talk about baby's head position and body position a little bit later on to kind of see how things are progressing and see how the pushing is going. Yeah. And I wanted to say too that although a lot of times you might hear about holding your breath and pushing or coached pushing, that's not always necessary to do. So if that doesn't feel like the right thing for someone to do, then they should breathe during the pushing or do what they feel is best for them to do. So delivery, I wanted to kind of show a cartoon of how what the baby's actually doing during delivery, which is kind of a set of complex movements. And so first the baby's head gets engaged with the cervix and the pelvis. And then the baby's head starts to kind of turn in a certain direction. And then the baby starts to extend the head and neck. And then, and that's kind of usually the first time that the baby is crowning and the head is coming out of the vagina. And then the baby's, so most of the time the baby is positioned where this is, and sorry to back up, this is a picture of someone delivering on their back. And so this is kind of the orientation of the mom, as you can see the spine down to the bottom of the picture and the uterus towards the top of the picture. Of course, this would be different if the patient was delivering on hands and knees or in a different position. So usually the most common position a baby's going to be in is where the back of their head is facing towards the mother's front. And that's kind of the easiest way for the baby to come out, because as you can see, the baby extends the head out and there's kind of a lot more room for like the baby's head to kind of move through the pelvis and come out that way. And then the baby's head restitutes or turns to one side or the other. And then the shoulders turn to match that side or the other. typically, it's at this point when the provider might put their hands on the baby's head to help deliver the top shoulder from under the pubic bone, and then help deliver the rest of the body. Sometimes during delivery, the provider might put some pressure on the area under, kind of between the anus and the vagina, to help prevent tearing of that area, to help put a little bit of pressure there to help prevent tearing. So those are just some things that a provider might be doing during delivery. And then typically, if the baby is delivered and doing well, crying, looks vigorous, is moving, and has a good, kind of pink or, color, not blue, the baby will be delivered to the mother's chest. And then the mom and baby can have kind of a skin to skin time, which is so important for bonding and for health. If the baby's looking sick, then the baby might be taken nearby to a warmer to get any sort of resuscitation to help baby breathe or help baby transition a little bit. And once baby's doing better, go back to mom. I wanted to talk a little bit, some questions that sometimes come up is the baby's head position. So as I was saying, the most common position that baby's head is going to be is called occiput anterior, or OA, and that's where the back of baby's head is facing towards mom's front. And these are some kind of versions of that. And that's just the easiest way. It's kind of the most compatible way that baby's head can fit through the pelvis as it's going through those movements that it does. If baby's head is faced the opposite direction, so baby's face is facing mom's front, then it's a little bit of a tighter fit through the bones of the pelvis. So sometimes that can make for a longer pushing period, and that can be a little bit difficult. But certainly a lot of babies are born that way. And sometimes if labor is kind of stalled out in that way, or pushing has been stalled, some doctors are able to turn the baby to the position of occiput anterior. Most babies turn themselves into the kind of most advantageous position. So that's delivery. And I wanted to talk a little bit about postpartum, kind of the very beginning. So I mentioned that usually the baby is delivered right to the mom's chest to start skin to skin. The first hour after delivery can be this really wonderful time of baby getting the warmth from mom and even starting to breastfeed. And so that is kind of a protected hour. Usually at Swedish, in the first 2 hours after delivery, the mom and baby are still in the delivery room before moving to a different room, part of the hospital, for postpartum. This is a time when, if there was a vaginal tear, the tear would get repaired. We keep a close eye on mom's bleeding and make sure there's no kind of increased level of bleeding that might be dangerous. And we give medicines if we are worried about the bleeding too much. If there's a vaginal tear and you've had an epidural, then you won't feel those stitches. But if you haven't had an epidural, then we would give local anesthetic to help numb the area, kind of like a dental procedure. And then in that kind of 2 hour period is time to kind of start bonding, work on breastfeeding. And then the baby gets an exam from providers and from nurses. And there's some typical medicines that are really, really helpful for baby to get in this time period, One is vitamin K, which is something that's really important for all of our abilities for our blood to clot. And so we don't make that when we first are born. And so getting that medicine in a shot is a really important medicine for babies to get, so that their blood can clot if they were to have a bruise or have any sort of injury at all. Hepatitis B vaccine is something that we recommend in the first day of life. And then ointment, antibiotic ointment for the eyes to prevent any sort of infection that baby might get. And then if there's any sort of complications of the pregnancy or labor, oftentimes we recommend checking the baby's blood sugar, because delivery can be a really rigorous process for babies, and they might have used up all of their all of their sugar stores. So we need to make sure that they're not they don't have too low of a blood sugar that can be dangerous. And then in the first, so usually we recommend that babies and moms stay in the hospital after a vaginal delivery for 1 day for 24 hours, and after a C-section for at least 48 hours, maybe longer if your baby or you needs more monitoring or care. There's some typical tests that we do besides those ones I talked about before at 1 day of life. One thing is a blood test that we measure the jaundice level for babies. All babies have some level of jaundice, but really high levels can be dangerous. And then we also screen for some rare diseases that if we can catch in the immediate right after birth can be life-saving. We also check weight, and we check hearing, and we check heart screening at 1 day of life. And then for moms, check on pain, help with any sort of bleeding that's happening, and then help with breastfeeding. So there's a lot of experts in the hospital that can help with breastfeeding, and just help manage the recovery, the physical recovery after birth. So that's kind of all I had. I know it's a little after 6. But if anybody has any questions for me or any points that they'd like to make or anything like that, I'd love to hear it.
All right, ladies, you have any more question about postpartum?
I wanted to just ask if you could talk a little bit about how routinely you all do episiotomy because of FGM. Sometimes people are actually persistent in like getting them. And can you just talk about the protocol of Swedish and that?
Yeah, my understanding, so I've never done an episiotomy. My understanding in general is that we don't recommend episiotomies routinely, but there's some indications for an episiotomy for anybody. So even in the situation of FGM, a lot of times people are able to deliver depending on kind of the extent. And the kind of natural tearing that can happen is often heals easier than an episiotomy. So we kind of, try to do perineal support to prevent tearing, but the natural tearing that might happen is, kind of preferred over doing an episiotomy routinely. And an episiotomy is kind of the cutting of the tissue. Usually you do it to the side rather than straight down, but kind of on the bottom of the vagina to get some more space. It used to be done a lot more routinely, but not routinely anymore. some indications for why it might be done is if there seems to be less space for baby to come out, and baby's heart rate is going down. And there's just a lot of concern about whether that that skin there is in the way, and baby's in trouble. So if there's skin there that's in the way and baby's heart rate is doing fine, then that skin will stretch, and that's okay. And oftentimes there might be, the provider might do some more gentle kind of stretching of that skin to help it stretch with their fingers. So another thing is if the baby's shoulder gets hung up on the pelvic bone, it's called a shoulder dystocia. And that can be really dangerous because it can, because the baby's kind of half born, there can be pressure on the cord that is preventing baby from breathing and from being able to get oxygen. So if that shoulder's hung up on the bone, then the provider needs to be able to put their hands kind of inside the vagina to help maneuver the baby out from under that bone, if that makes sense. And so if there's not enough space for someone's hands to kind of go in there, then there might be an episiotomy cut. But certainly you don't necessarily need an episiotomy for that. There's definitely times when you can do maneuvers to help resolve a shoulder dystocia without doing an episiotomy. It depends on how the tissue has stretched in this, and that's a certain situation. Does that help answer that question?
Yeah, no, the reason why I asked was because I know, due to the female genital mutilation and stuff, and there are some women in our, community that are very, they're like, my baby's not going to come out unless I get cut,
Mm-hmm.
and we do talk to them about the fact that it's better if your body sort of, gives itself rather than, it being cut. So that's why I wanted you to sort of talk about that. So that sometimes things go a long way when it comes from your doctors, then when it's somebody from the community, even though you have a medical training, it's just like, it doesn't carry the same weight. That's why I wanted you to sort of echo those. Yeah.
You're totally right. No matter if you've had like a procedure before, to kind of close up that area, that tissue stretches, and it's hard to predict, and can tear, and might tear along where things were kind of closed. So the natural tearing is a lot better for healing, and that's kind of what we think. And we will kind of repair the tears, but we don't, sometimes things don't tear. So we don't want to assume the way the body is gonna, the way things are gonna give way naturally is often a healthier and safer way for things to happen than us cutting. So there's a couple other questions in the chat. One thing was jaundice. So I mentioned a jaundice level in babies. So jaundice is a chemical that our bodies make, or jaundice is the term for bilirubin, or high bilirubin. And bilirubin is a chemical that our bodies make that's actually when our red blood cells in our bodies, the red blood cells that carry oxygen around our bodies, when they break down, and they break down all the time, every 3 months, there's turnover, and that's a natural process in our bodies. The breakdown product is bilirubin, and that is processed through the liver, and then it's actually pooped out and peed out of our bodies, and that's what makes poop brown. So, but babies have kind of a new liver that's kind of slow at processing bilirubin. And so they all have a little bit higher bilirubin than someone who's older and has a liver that is kind of faster and better at it. So, and there's certain things that can make bilirubin higher. If a baby has a bruise, if a baby has, which can happen from kind of which can happen from like a vacuum procedure or a forceps procedure, or even just a natural vaginal delivery of having the baby's head kind of get squished and squeezed through the birth canal. It can happen if a blood type from baby and mother are different, and that can cause really high bilirubin or jaundice. And if jaundice is really high, then we would do phototherapy, where we give the baby really cool little sunglasses and shine a light on their bodies, and that helps break down the bilirubin. Bilirubin and jaundice, if it's too high, can cause dangerous, can cause seizures and can be bad for the baby's brain. So that's why we care about it. But oftentimes most people have a kind of medium level, and it's okay. And the way to help flush bilirubin out of the system is make sure that the baby is like hydrated and pooping well and peeing well. The other question about how likely is it to have a vaginal birth after, do you say 5 C-sections or a C-section? 5, okay. So a vaginal birth after C-section is completely dependent on the reason for the C-sections and kind of the mom's health history. And so typically what we recommend is going and talking to an OBGYN and having a discussion about all those different factors, how many C-sections you've had, why you've had those C-sections. There can be different reasons that people have C-sections, and those different reasons might make it more or less optimal to have a vaginal delivery, or I guess more or less likely that a vaginal delivery is will happen. And so that's a very specific question, kind of dependent on the person. I think 5 C-sections is, I think it might be a little tough to have a vaginal delivery after that, but I would never say never. And I think talking to an OBGYN about someone's specific situation is the way to go.
How about the postpartum?
Mm-hmm.
How are you gonna know when the patient have postpartum, the beginning, after they deliver?
Postpartum?
Yes, the sign of postpartum, like when they deliver. Or they're gonna know like when they go home or in the hospital. How are you gonna find out if the patient have a postpartum depression?
Postpartum depression.
Yes.
That's a great question. Postpartum depression is something that is really common, unfortunately. And sometimes people might have a history of depression in their life before they were pregnant or while they were pregnant.
Okay.
And that can sometimes make it a little more common to have postpartum depression. Mm-hmm. It's really common for people to feel a lot of strong moods, ups and downs after delivery, because the hormones in your body are really up and down after delivery. Mm-hmm. And so we can't always tell. We always want to ask about how people are feeling after delivery, but in the first couple of days, it's often really hard to know. And so it's something that doctors and midwives should be asking at every follow-up visit. And that's why it's important to see your doctors and midwives, sooner than 6 weeks after delivery, even in the first 2 to 3 to 4 weeks. And some things to think about are that postpartum depression, so postpartum low mood is so common in the first 2 weeks, and oftentimes after 2 weeks after postpartum, moods start to feel a little bit better. but if they don't, then that's also a time to talk to a doula, a midwife, a doctor, to get more support. And the other thing is just, it's such a huge adjustment. There's so many hormones going on in your body, and there's so much sleep deprivation that the ability to cope with any sort of change can be really hard. And so having support where you feel comfortable talking to a loved one or to a doula or to your care provider is so important to be able to like communicate what's going on. And there's also a lot of resources to be able to call people and to be able to kind of seek support outside of your community or outside of your family if you feel like you need to talk to someone who isn't in your life. But it's hard to make that diagnosis right after birth. It's something that we always have to keep talking about and keep checking in about.
Is there anything to prevent like the postpartum depression without taking a medication?
Yeah, that's a good question. I would say being really trying to get sleep, trying to before delivery, trying to rally a community around you where you feel supported.
Okay.
And then if you have a history of depression, making sure that you are talking to doctors and midwives about that. Sometimes people need to be on medication, and there's medication for depression, or you say not on medication.
No.
Yeah,
Yes.
I would say counseling is really, really helpful, talking to people and talking to people in your life, but also talking to people who are trained to help with postpartum depression.
Okay.
Yeah. And Swedish has a whole department that focuses on mood and depression in pregnancy and after pregnancy.
I'm not sure if they have people like if you to me, I never had a postpartum depression, but I feel like I have a postpartum depression the beginning, like first 3 months.
First 3 months after, or
during the pregnancy, I go through a lot. I'm not sure if anybody else like me, or there's a lot of women like that. You feel like you are depressed.
Yeah.
Like you throwing up nonstop. You don't want to see nobody. It's overwhelmed.
Yeah.
Not like after the birth is beginning. When a person have a lot of pain, throwing up nonstop. I feel like I experienced postpartum depression the beginning, like.
Yeah, like in pregnancy.
In pregnancy.
Yeah, and I don't think that, I think that's common. I think that is something that is, I mean, you said it, you're throwing up, you're nervous and maybe stressed out about your pregnancy and your health. There's all these changes going on. You're still expected to, be a mother to other kids, to
and poor eating also.
These things, and it's so hard. And I think at any time, whether you're pregnant, whether you're postpartum, or even none of those, life can be overwhelming and depression can happen. And I think talking to a therapist and counseling can be a really helpful way to treat that, but also by having a strong community and getting help from people to help offload your plate, help and help manage symptoms that are making it worse, like nausea and vomiting and things like that.
Oh wow! I wish if I talk about it, but if somebody like me, if they have a lot of women like me, very common. So we need to help, like, to talk about the beginning. If you feel like that, you have support or somebody to call.
Yeah. And I'm not sure, are there services with the Global Prenatal Services for like calling, like hotline things, or for?
Or when they come to the clinic, if they have like a flyers, like somewhere they can go or talk to them or support.
Yeah.
Yeah. In the beginning.
Support
What do
group.
you think? Did anybody has that problem, like facing it? I face my 4 kids is just overwhelmed every time. I don't think the birth, I'm thinking about the beginning.
Yeah.
Like I become overwhelmed.
Yeah. There's some groups that do what's called centering pregnancy, where you have pregnancy, and unfortunately my clinic doesn't do this. I wish they did, but where you get your pregnancy care in groups of other people at the same stage of pregnancy.
Oh, wow.
And then you can have this little support group.
And they talk to each other and all that.
They talk to each other, and you go in and you get your lab testing and you talk to your doctor and you have your group, and it's really supportive. And certain clinics do that, and it's called centering pregnancy.
Oh, wow. So it's something they can, is going to help our community also, that one.
Yeah. Yeah.
Centering pregnancy, Colombia, I think they do it right now.
Yeah.
Some clinics they do it. I wish Swedish would do it, but
yeah,
hopefully maybe the near future.
Yeah. I agree.
But I think
the
guys,
thing is,
any more questions? Sorry.
Yeah,
I'm
get a
driving,
doula.
by the way,
If you
at the
get
same time.
just get a doula, and you'll be connected with all those services. If you're not sure where to go and who to speak to, you can contact us, Global Prenatal Services, if you don't have doula, and then we can hook you up with a doula.
Yeah. And then also there's the public health nurses that also can connect people to doulas and resources too. But yeah, doulas in the beginning of pregnancy.
Yeah.
At any stage.
Yeah. I wish a brochure, if they have, like Swedish, every clinic, they have the doula services, like they can grab and give it to the brochure, for the pregnancy.
Yeah, now they do. Swedish have a doula services, but
that's better.
Not on the clinic, but when you go delivery, if you want to, like doula, they will give it to you. Yeah, they do. They have on-call doulas too.
Oh, okay.
I think it depends on what clinic you go to, because I worked at neighborhood house where they help you with if you want to talk to somebody, they have like psychology or someone there that you can talk to.
I got disconnected. I'm sorry, everyone. Any other questions?
Well, thank you so much, Dr. Guthrie, for coming today. And I know it's Ramadan. The ladies are, preparing their iftar. And I'm doing a postpartum presentation tomorrow. Is there any way, do you have any slides? You can email it to me.
Yeah, I can see if I have anything.
Yeah, just whatever you got. Yeah, I have some too from Faiza. So I'm just going to, put it together and present it to the community.
Wonderful.
Yeah.
And I was thinking, so maybe we can email about next topics of maybe C-section, inductions, complications, things like that.
That would be great. Awesome. And I will email you that, but next month we should definitely do that.
Okay.
Inductions and complications.
Will do.
During delivery.
Yes.
Thank you. Thank you so much.
You. Okay.
Thanks for coming.
All right. Bye-bye.
Bye, ladies. Bye, everybody.
Bye.
هالو يا وين
سعاد
سعاد واك بحد ملقمي يا قفنا يا وين
ها
آسي وين ملقو يور ساتاي
باي آسي عفمات هذا
في عنا الحمد لله خير يور هذه
وفي عنا باي الحمد لله been long time
عروتك for a long time yes